Good afternoon, honorable guests. I would like to welcome you all to this conference entitled The Transformation of Pharmacy Practice Towards Patient Care During the COVID-19 Era. This event is a result of collaborative efforts between the Journal of Pharmaceutical Policy and Practice and the EMRO Pharm Forum. In addition to exploring the transformation of pharmacy practice during COVID-19, this conference will explore the role of the FIP Development Goals in the pharmacy practice transformational globally. It will identify practical strategies and WHO roles and challenges in vaccines transformation globally, and ways to help community pharmacists improve their medication-related problems solving in community pharmacies. In this conference, we aim to understand the role of accreditation in education transformation. Second, to describe the education transformation challenges in many countries in the Eastern Mediterranean region, such as KSA and Lebanon. Third, to describe approaches to establish interprofessional education and practice. The fourth, to understand the telepharmacy and new emerging opportunities to improve pharmacist role in patient care. Therefore, I wish this conference will help in presenting ideas and approaches that would advance patient care in our region. Thank you for your attendance. And now I would like to yield the floor for our honorable speaker, Dr. Dominique Jordan, the president of FIP, to give his speech. The floor is yours, Dr. Dominique. Thank you very much.
Thank you very much, Nadia. It's my pleasure to be with you today. And I want to thank the EMRO Pharm Forum to have organized this conference. It's very important for pharmacists to be supported because, as you said, we are transforming the profession. And just to mention that FIP is unique because we have within FIP education, science, and practice. And these three domains are very crucial for the development of the profession. We can see during this pandemic that in a lot of countries, pharmacists had new roles like vaccination or testing. And especially in the topic of vaccination, we can understand the importance of having appropriate education. And it's the reason why I always say practice without education and science is nothing. The first step to be professional is to be well educated. And this kind of conference give our pharmacists and member organization the opportunity to see what other countries are doing and learn of this experience. And this is also the added value of FIP, having the possibility to share information, experiences with other countries and other parts of the world. FIP try to support member organization and pharmacists. You will see by the presentation of our CEO that last year we launched our FIP Development Goals, and this is a very important issue to try to give a direction to the evolution of the profession all over the world. We created also different provider models so that we can share information and experience and projects from one part of the world to the other one, who are countries who need some support. And what is very important for FIP is that FIP is not coming to a region and telling the people what they have to do. Every country, every region of the world will decide on their own strategy and own important development. It's a reason why we have created different models so that we can support member organization in their effort to implement some new projects. And the last project I want to mention is the GPO, the Global FIP Global Pharmaceutical Observatory, who should have very important data and transform this data into intelligence so that we can give some information to different countries all over the world according to the data that we will become from the different information that we will have. So having this in place, I'm sure that the role of the pharmacist will increase and the role of the pharmacist will be consolidated in the future in our health system. Because I always say that the 21st century will be the century of the pharmacist. Just look what happened during the pandemic. Through or thanks to the pharmacist, the chronic patient could get the medicines. And now a lot of countries give some new roles to the pharmacists because they understood that the proximity of the community pharmacist in the heart of the community is very important to be able to take care of the people around the region. So that, thank you very much for your engagement. Thank you very much for the work you have done during this pandemic, and you will do also for, I think, a few months, if not a few years. But through our hard work, our daily hard work, we could prove to the government that the pharmacists were very important for the health system in all the region of the world. So together, I'm sure we will be successful, and it's the reason why it's very important for you to attend this kind of conference. And I want to thank the speakers to share their experience and new models with pharmacists so that we can together be fit for the future. Back to you, Nadia, and thank you very much again for organizing this conference.
Thank you very much, Dr. Jordan, and thank you for this nice talk. Amazing talk, and thank you for your support for all the forums, especially our EMRO forum, and thank you very much for supporting the pharmacist world globally. And with you, we can do a great change and a transformation, and it will be a concrete one, solid one for all the countries together. We want all of us to do the transformation in the sake of pharmacy profession as all. Worldwide. Thank you very much. Thank you.
Thank you.
Thank you very much. Now, I would like to invite also my Dr. Wael Ali, EMRO General Secretary, my friend and my colleague, and he is really, I would like to thank him because he's doing a great job for our EMRO office, running all the EMRO office in Egypt. And thank you very much. Dr. Wael, the floor is yours. And you're welcome to give your introduction about the EMRO, about everything, and to give your speech. Thank you very much.
Thank you so much, Dr. Nadia. And always you did a marvelous job. Thank you so much for all attendees. Thank you so much for FIP, Dr. Dominique, and Dr. CD. You know, I promise this 2 days event, it will be amazing. I'm so happy to hear that, or even to just read someone is my colleague, for example, from Margarita from Jamaica. She said, good morning, it's 8 a.m. right now there. And from Philippines, Nelson and Dan, they said, good evening, we are from Philippines. And Nadim from Qatar, good evening. And here from Egypt, good afternoon maybe. And Khaled from Libya, Musrata, and Maysoon from Emirates. It's so amazing to find all of these colleagues in just one event. We're gonna share a lot of things, a lot of marvelous things. I believe in that. And I wanted to say something before EMRO Forum. And what about the EMRO Forum? JoPPP. It's very amazing to have Dr. Zahir here. It's a journal of pharmaceutical policy and the practicing. And this is very important, the legal part and the practicing part, and even the education part. So we will enjoy about these 2 days regarding to our speakers. It will be very, very amazing. We are EMRO Pharm. We are our office, regional office here in Egypt, and we are working together with FIP to make one FIP, how to communicate, make a bridge between even all the countries, all the colleagues, wherever we are. FIP, we have 4 million individual members, pharmacy and student, and even technician in just one umbrella. And we are EMRO here, we are serving almost 22 countries in EMRO. So we are serving you here to help you, whatever you are in education level, or even you are in the practicing level. Okay, so it's a time to introduce Dr. Zahir. So let's go to the first presentation. I mean, Dr. Zahir, he's a president of journal, he's a professor of medicine and the healthcare department of pharmacy from UK and the editor-in-chief of Journal of Pharmaceutical Policy and Practice. Please, Dr. Zahir, you have a floor right now. Go ahead.
Thank you very much, Dr. Wael Ali, for inviting me to present on this conference.
You're welcome.
Okay.
Yeah, can you share your screen? Yeah, go ahead.
I'll share the
It's
screen.
working right now, thank you.
Yeah, so first of all, I would like to say thank you to EMRO Pharm Forum and FIP to joining partnership with Journal of Pharmaceutical Policy and Practice. It's an amazing opportunity actually to showcase on the recent issues which are impacting on pharmacy practice. So in this presentation today, I will be talking about practice and what future direction. And as you mentioned, Dr. Wael Ali and Dr. Nadia, about that in EMRO countries, there is a lot of young people, young pharmacists. So the issues which are impacting on them could really be important to change the health outcomes. So I'm going to talk about why it's important to have pharmacy practice research. And I'm going to share some of the examples from COVID-19 and pharmacy services research as well. So why research is important? Research is not just for academics, but it's about real issues that affect patients and pharmacists. And there is a scarcity of evidence-based research in pharmacy and pharmaceutical public health. So in fact, there are very few studies which are basically talking about pharmacy and pharmaceutical public health. And in the recent past, so there were a number of studies, the number of studies were increasing, but we couldn't really see the impact of those studies. So the types of research which is being performed in pharmacy practice, if we look at the types of research, we see in the evidence hierarchy, there were meta-analysis, systematic reviews, and randomized control trials. But from experience, we know that we really have to make a difference in pharmacy practice research. Then, of course, we have to conduct more RCTs, we have to conduct more meta-analysis, and we have to conduct more systematic reviews in this context. But there was a scarcity of pharmacy practice research literature. So the last year we published a research which actually showed us that there were currently 39 systematic reviews relevant to pharmacy practice research in the Cochrane Library. So if you look at Cochrane Library, there are hundreds and hundreds of systematic reviews. And as you know very well, that Cochrane is used to inform policy and practice. But if we see the share of pharmacy or pharmacy practice research, there were very few Cochrane reviews, just 39 as of last year. So the review team is almost always multidisciplinary, leading to less likely to be biased in favor of pharmacy in the interpretation and reporting. So looking at the evidence, if you look at the evidence which is being done in these Cochrane reviews, so for example, looking at this, there is the effectiveness of intervention by community pharmacists for smoking cessation. So this has been cited a lot, but the strength of evidence was limited because only one of the trials showed a statistically significant effect in this context. This was another study looking at pharmacist-led medication reviews and hospital admissions. And it showed that pharmacist-led medication reviews and interventions can't reduce hospital admissions or mortality rate in older people. Though these interventions may improve drug knowledge and drug adherence, but there were insufficient data to know whether the latter affects patients' quality of life positively. But in this, we started to see the evidence, which was really good evidence. And Australia shows a sort of an example in terms of home medicine review, where the pharmacist actually really worked hard to improve the patient health outcomes. And as a result of that, the 5-year community pharmacy agreement budget was $5 million Australian dollar. In the second agreement between the government and the CPA, which actually increased to $663 million in the fifth CPA agreement. So here is an example where you could see the research and the role of pharmacists is directly transformed into improving something in terms of health outcomes and impact on ground. This was another review in clinical pharmacy telemedicine intervention. And this was done via phone, and it had an overall positive impact on outcomes related to clinical disease management and patient self-management. In terms of looking at pharmacists in COVID-19 research, because all of you know that pharmacists have played and still playing a very important role. So just looking at some of the studies in terms of what pharmacists have been doing and how it's impacting on in terms of medicines use and pharmacy services and medicines impact. So there was a very good paper published in 2019 on role of pharmacist in disaster, which actually looked at the 43 pharmacist role, looking at medication supply, vaccination, and education, the patients and consumer. And as you know, that the pharmacists are leading the front in terms of prevention, preparedness, response, and recovery efforts in a very, very short time frame. In terms of pharmacists and COVID-19 research, large number of research articles are being produced. And there are also policy guides from FIP and CPA and RPS. But it's important to note that how many of these research articles are actually being used in policy development and in practice. A number of them are published in form of original research, commentaries, reviews, editorials, and so on and forth. So for example, this is one of the earlier paper which is being used in COVID-19 and pharmacy research. And in this paper, the Chinese and English databases were searched, and it was observed that clinical pharmacists were involved work against COVID-19. And they were actually helping to formulate telehealth strategies and also to provide innovative pharmacy services. This was another systematic review, the earlier systematic review published, and it actually synthesized and documented 9 primary studies published between 2019 December and April 2020. Most studies were from USA and China, and no information was actually on the actual intervention on COVID-19. This was another systematic review which was conducted in 2020, and it identified 15 studies. And these 15 studies were related to chronic disease, medication supply, education, health policy and population, role in response to patient care and clinical roles, restocking emergency kits, and re-establishing normal stock. There were a number of other papers who were actually talking about the additional roles which pharmacists can perform, ranging from emergency supply to management to prescribing, to drive-through pharmacy to point-of-care testing, as well as the vaccination. And actually, the studies were quite widespread, ranging from Commonwealth countries to India, Poland, and US, and they were all involved in disaster response and mitigation efforts so that they can ensure medication supply and patient care. This was a recommendation from a panel of experts, which FIP convened last year. It actually focused on 4 issues ranging from medicines and vaccines, service-focused workforce issues, and pharmacy education and training. So this is a recent paper which came out this year, and actually looking at how COVID-19 has impacted the role of pharmacists around the world, and looking at COVID-19 testing in France, Spain, Switzerland, and UK, and in some other countries. Challenges which were faced by COVID-19 and ranging from, so there were a number of studies which actually documented those challenges, ranging from price increase by the wholesaler and suppliers, frequent inspection from authorities, extended working hours, financial loss, reimbursement delays, and mental health issues which were impacting the pharmacists. So this was a sort of the evidence which we have, which was produced related to COVID-19 and pharmacy research. And last year, I was also involved in a study which was done by Pharmaceutical Group of European Union with Portuguese pharmacist and my colleague Suzette Costa from Portugal. And this was a pharmacy intervention in Europe, mapping, practicing, and scoping review. And this review involved 32 European countries. And actually, it looked at the interventions which were done in Europe. So there were 31 pharmacy interventions on COVID-19 in 32 European countries. Most studies were cross-sectional or descriptive. There were a wide variety of pharmacy intervention related to COVID-19, which were implemented in many countries in a very short time frame. And these findings actually, they provided that there was significant impact to improve pharmacy research, policy, and practice in response to future public health emergencies in Europe and globally. There were extended powers granted to pharmacies and legislation passed in view of COVID-19. It had allowed pharmacies to provide services to improve access to medicines, products, patient screening, referral, including point of care testing, and vaccination as well. So these are 2 studies which are actually not published yet, but in the process of publishing. But they actually show you large number of pharmacy interventions which were done in 32 European countries. So there were about 31 pharmacy interventions. So in turn, what is needed to produce evidence-informed research in COVID-19? If you're working in this direction or pharmacy practice research, of course, you need human resource. You need to have a good understanding of methods, whether they are quantitative or qualitative, systematic reviews, meta-analysis. You need to have a knowledge of health systems. And in regards to the country health system, the country in which you're working, the global versus local understanding, and understanding how this research would be used. This is pretty important to look at the research which you are going to produce, how this would be used and who will be the end user. The today's presentation is that there is a changing role of pharmacists globally, including the EMRO region, which include 22 Eastern Mediterranean countries. There is a need for original research. So what would be these research questions? Pharmacists' role in medicine information with the increasing information and literature for patients, remote counseling, and drug shortages during the pandemic. So these are the key issues which are coming and which we see globally coming in the literature. So with all, I would like to conclude my session here, and thank you. Thank you very much.
Thank you very much, Professor Zahir, for this informative and amazing really lecture. And really, your journal is doing a great efforts in supporting research worldwide. Thank you very much for your support, for the EMRO, for everyone, and thank you for your presence with us, which we find you very valuable for us. And inshallah, we keep doing a lot of functions together. Thank you very much, Professor Zahir Badia. Now we will go to Dr. Catherine Dogan. Catherine Dogan, CD, is the dynamo of FIP. She is the FIP Chief Executive Officer in Netherlands, but she is in our heart of all the forums, and she's doing a great job in supporting the pharmacy transformation through application or trying to identifying the FIP Development Goals role in pharmacy practice transformation globally. Especially, she is taking care of implementing the vaccination for all the pharmacists globally. Thank you very much, Dr. Catherine, and the floor is yours. You can start your presentation. Thank you very much.
Thank you so much, Dr. Nadia. A great pleasure to be here with you today, and thank goodness we can be together, even if it's just through our technology platforms. At least we are still in touch. I'm delighted to be here today. The title of my presentation is The Role of the FIP Development Goals in Transforming Pharmacy Practice Globally. And Dominique mentioned where these fit in the jigsaw of FIP. So I hope my presentation will help to tell you more, all the colleagues on the call, and to walk you through some of our plans for the implementation of these goals to support that transformation. Next slide, please. So you know about FIP. We were founded in 1912. The International Pharmaceutical Federation is a global federation of more than 170 national and regional organizations and academic institutions. We represent 4 million pharmacists, pharmaceutical scientists, and pharmacy educators. Next slide, please. We are a non-governmental organization, and we've been in official relations with the World Health Organization since 1948, since it was set up. And then in May 2019, FIP and the WHO signed a memorandum of understanding to really strengthen our partnership around workforce, patient safety, primary healthcare, and other areas, really to consolidate the joint working we've been doing for so many years together. Next slide, please. Our vision is for a world where everyone benefits from access to safe, effective medicines and pharmaceutical care. And we know this is the most important vision such a federation as ourselves can have, especially during the time of a global pandemic. Next slide, please. Our mission is to improve global health by supporting the advancement of our unique practice, science, and education, and thereby achieve our vision. Next slide, please. We have 6 strategic outcomes that form the basis of everything that we do. Number 1, that everyone has access to the medicines they need. I just said how important that is during a pandemic as never before. The second is that everyone has access to health and medicines related information they need. And our pharmacists have done us proud through the pandemic, showing what they do every day in practice to ensure these two are in place. Number 3 is that everyone benefits from new medicines, services, and health technologies, and it is up to FIP to ensure we are all informed and aware and educated of these innovations. The 4th is that pharmacists are there to ensure the responsible and quality use of medicines, and we will support all our countries and all our member organisations to ensure health ministers and governments are aware of the secure place pharmacy has at the table of healthcare. The 5th is that healthcare professionals and patients work together to ensure comprehensive healthcare for all. We know, colleagues, pharmacy can't do it all on its own, so we need to collaborate with our nursing colleagues, our doctor colleagues, our physiotherapists, our dental colleagues, all of the health professionals that we encounter, and our patients and our communities. And finally, as a CEO, with my colleagues at the H quarters, we have to ensure that FIP is vibrant and growing, and that we meet the needs and functions of you, our members. Next slide, please. Since 2018, we've presented this concept of one FIP, and we've been working on all the elements since then. No other organisation, as Dominique rightly said, combines science, education, and practice under one roof. Next slide, please. So I started at the Federation in this role in June 2018, and Dominique was voted president of FIP in the September that year in Glasgow, where we had our Congress. We then attended the Astana Congress in Kazakhstan in the October of that year, where the 40th anniversary of the Alma Ata was being celebrated through the Astana Declaration. We made sure that FIP signed up the profession to the Astana Declaration, ensuring pharmacy is seen and visible in playing its role in delivering primary health care and universal health coverage. We made sure that we were central to this, and how interesting that since the pandemic, pharmacists have been central in every community. Pharmacists who practice at the heart of the world's communities make huge contribution to primary health care, and it's important that we demonstrate this and we demonstrate evidence of impact of our role. So journals such as we've seen today and congresses such as this one are super important. And even though we cannot be face to face, let's continue to meet and share, as Zahir has rightly said, through our virtual means, because at least we are still in touch. Next slide, please. So we mobilised around our signatory to the Primary Healthcare Astana Declaration by holding 2 regional conferences in 2019. The first was in Amman in Jordan, which represented the Eastern Mediterranean region, but we had a global attendance at that conference. And here, the region signed the commitment to primary health care, a version of what we had signed in Astana, really making our commitments verbalised, vocalised, and evident to all. Next slide, please. And in order for us to be able to demonstrate the impact of our profession to everyone, it's important that we align with the Sustainable Development Goals that the UN have published. If you can click for me, the next slide. You can see that goal number 3 is something that pharmacy has been paying a lot of attention to. I wanted to walk you through the work of FIP that has contributed to alignment with WHO. So in 2016, FIP published the Pharmaceutical Workforce Development Goals in Nanjing in China, November that year. And this was in direct response to the publication of the Human Resources for Health vision from WHO. For FIP to ensure we are aligned with their need for the workforce that we have and the workforce that we need, and for pharmacy to play its role in delivering the workforce that we need for patient care, it was important that we aligned our goals with the SDGs. Then in 2017, the FIP Nanjing Practice and Workforce Evaluation and Report was published. And in 2018, the Workforce Development Hub was set up in FIP. You'll remember we signed the declaration, the Astana Declaration, in the October of that year. And subsequently, we signed 2 MOUs with our colleagues in Jordan and our colleagues in Indonesia to set about some workforce transformation programs. Last year, we had always planned to launch the FIP Development Goals. These build on and consolidate the workforce development goals, but expand them to ensure that we have science and practice in each of the goals, and expand them to include 8 new goals to make a total of 21 development goals. We made sure that these were launched on the 21st of September last year in World Pharmacy Week to set the tone of that week and make sure that the profession would be supported. Then this year, the first of 2 years of implementation before we present at our Health Ministers Summit in 2023, we have a series of events and a series of prioritisation and engagement with all our members. As I mentioned, we are planning the Health Ministers Summit in 2023, and there the plan is that we will present evidence of impact against those goals, particularly around our commitments to the Astana Declaration, pharmacist contribution in NCDs, safety and prevention. And then, of course, the goals take us beyond 2023 to the 2030 deadline, which is what the Sustainable Development Goals link to. Next slide, please. Our 1 FIP goals really pull together the fact that we cannot have any pharmaceutical care without a pharmaceutical workforce, but actually we can't have any pharmaceutical care without a scientific foundation for the next decade. I think the COVID experience has taught us all that without science and innovation, and particularly pharmaceutical science and innovation, we cannot work with drugs that already have a license and repurpose them. We cannot identify new entities and create new molecules and new medicines for patients and the public. And we cannot mobilize the safety of those products. Next slide, please. So we have 21 FIP development goals, ranging from academic capacity all the way through to sustainability. Each of them relevant, impactful, and important. And each of them will have a different level of importance in each of our countries and regions. So without further ado, I just thought I would spend a moment on the next slide to showcase a video, all the goals. Thanks so much. So it's important for us to think about how to deliver these goals. It's enough for a profession to have goals to aspire to in one way, but without delivering against those goals, then really they are just words. So we believe it's an imperative to bring science, practice, and workforce and education together into a transformative framework for our members and the wider profession. Having these 21 goals really clearly sets out the direction for us for the decade ahead. Next slide, please. Each of the goals is composed of 3 elements: practice, science, and workforce. And we know that for each country or for each region, they may have a different emphasis. There may be a different priority, both in terms of the elements within the goals, but also the goals themselves. And each of these goals will be supported by a set of tools and structures, and also the indicators that we can use to show the evidence of impact. Next slide, please. You can see workforce, practice, and science in each of the goals is denoted by the little letter at the side. Next slide, please. There's a lot more about the development goals in our publications, and we'd love you to follow us, to engage with us, to share your thoughts, your feedback through all of these hashtags, and also the website that's listed just here. Next slide, please. We've been undertaking a series of regional engagement events and also in-depth events with our member organisations to find out across all the 6 regions which are the priority areas or where they have work already underway. And you'll see from this very high level colour chart that most of the goals are being covered in many of the regions. There are a couple of gaps there, and I just thought I'd make a mention that number 17 is antimicrobial stewardship, and that one we have got regional roadmaps and a global plan. So where we may not see activity being recorded in the regions, we know it is happening. The same is true for equity, and actually we have 2 big programs of work on equity and sustainability, which seem to cover most of the other goals as well. Indeed, if you think about the FIP vision, it's really about goal number 10. How can we ensure everyone has access to safe and affordable medicines? Next slide, please. Then when we dig a bit deeper into the Eastern Mediterranean region, for example, we can see different countries have different priorities and different programs of work. We know that Jordan, Kuwait, Lebanon, and Egypt have fed back to us their high-level priorities. And then we have an FIP program of work where we look at all of our member engagement and needs, their education and training needs, and do an assessment for each country. And you can see in this picture here the different priorities that different countries have. And I think it's really important, colleagues, for us to note that if we do a global map of this, then we will have most of the goals covered. And also where countries have needs, other countries will have provision that we can use through our provider model that Dominique mentioned earlier on. Next slide, please. It hasn't come out very clearly, but here we have details of our different organisations with each country. We'll make sure that the text is clear for all of you when we share the slide. Next slide, please. We've got a series of 21 events in the year 2021 on each development goal. And you can see that we've had goal number 4 and goal number 7 in August, and we have a set of other goals in September, October, November, and December. All of these are recorded. So I would urge you to go to the events.fip.org site and make sure that you listen to each of the development goals in depth. They have run from March, as I mentioned, and run all the way through to December. Next slide, please. You can register free at the website that's listed here, and then please attend. Feedback. Let us know what your priorities are. If we can collate a global map that shows that we are progressing against each of the goals, if we can collect data through our Global Pharmaceutical Observatory, and where countries have needs and priorities in different areas where they have gaps, then we can match them up with colleagues who have developed services or provision in some way, shape or form. It would be our vision at FIP to provide member organisations and members themselves with quality assured, quality marked provision that they can trust and that is of the highest standard possible. Next slide, please. Here's a couple of ways in which you can engage with us. The virtual events I mentioned, that this is a great way for us to be in touch, especially when we cannot be face-to-face or shoulder-to-shoulder. We also have a presence on Facebook, LinkedIn, Instagram, and Twitter, and we'd love to engage with you all. Please do. And of course, join FIP. It really is a great federation to be part of. We really are the pharmacy family in action. Next slide, please. I just wanted to mention before I hand over to Dr. Nadia again, just how thankful we are, and a great big thanks to the team at FIP who has been working hard behind the scenes to support the event today. Dr. Nadia, we are delighted to be working so closely with you at the EMRO Pharm Forum. Thanks a million.
Thank you so much, Dr. Catherine. Thank you, appreciate it. Yeah, it was marvelous presentation. Thank you, appreciate it.
Thank you, Dr. Wael.
So
sorry.
As usual, yeah, no problem. Thank you so much. You know, as usual, Dr. Catherine, she's FIP CEO, and always she inspires us. Yeah, really, she inspires us to do something shoulder to shoulder. She loves to say that when we are working, she said we are one family. Yeah, we are pharmacists. We are one family. We are working together, shoulder to shoulder. So thank you so much. You know, we believe that 21 development goals of FIP to become one FIP, it's not like, you know, by chance or by accident. No, they were working starting from 2017 to do something report from Acetana. And then 2018 made something called Workforce Hub. And then 2019, they made it like transformation program of the workforce. And right now, I mean, in 2020, it was the development. I mean, it's like a birthday of the 21 development goals to make it like easy to work as a one FIP. So thank you so much, Dr. Catherine. Let's go to a presentation of Dr. Nadia Mazroui. Dr. Nadia Mazroui, she is our president in EMRO Pharm president. She is a professor doctor in Sharjah University in Emirates in Faculty of Pharmacy, and she is a consultant in WHO too, one of the leader here in our region, EMRO countries, in the pharmaceutical science, practicing, and education. So let's go to Dr. Nadia and her presentation. Thank you.
Thank you very much for the invitation to this conference. My presentation will be about educational intervention to improve medication-related problems, MRBs. And this is some biography about me and some activities I am involved in. We are going to, I'm going to give some brief about coronavirus, also some summary, a disease that it is corona disease. It started COVID in 2019, caused by severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2, and initially discovered in Wuhan, China in December 2019. Declared a public health emergency of international concern on January 30th of January 2020. The incubation period is between 2 to 14 days. Main symptoms, mild to severe fever, dry cough, loss of taste, smell, aches and pain, and rash on skin, and shortness of breath. Its symptoms can be persist even after recovery and may cause serious complications. So it is also identified in more than 200 countries and territories worldwide and can be transmitted by direct contact and through the spread of respiratory droplets from coughing or sneezing. Several vaccines have been designed and approved to prevent the infection. Citromab, which is a monoclonal antibody, has been recently also approved by Ministry of Health as a COVID treatment in UAE. As in June 2021, more than 173 million COVID cases have been identified worldwide, and of which 3.72 million individuals died due to COVID complication. So we are going now to see what's the pharmacist's role in improving medication-related problems during this pandemic. So the pharmacist's contribution to the optimization of drug therapy may be evaluated by ascertaining the number of drug-related problems addressed or prevented, or by assessing the clinical outcomes for the patients. Several studies indicate that the pharmacists working in community settings have the responsibility of identifying and resolving MRBs, medication-related problems, thereby improving patient safety and decreasing the cost of inappropriate use of medicines, and minimizing the burden on healthcare sectors as a result of increased hospitalization and emergency care visits. Also, intervention by pharmacists improve the clinical outcomes, such as improvement in levels of markers for drug use and disease. For example, more optimal lipid levels or INR levels, reduced length of hospital stay, fewer readmission, and fewer disease events such as heart failure events or thromboembolism. So our problem we are facing in EMRO region that there is inadequate documentation of MRBs, and also pharmacist intervention are not accepted by physician and patient. In some countries, pharmacist intervention are unauthorized also, and pharmacists poor knowledge, skills concerning identifying and correcting MRBs. The absence also, one of the challenges is the absence of plans for continuing professional development. So educational intervention has been used to improve the knowledge and clinical skills of pharmacists who must provide specialized care for example, an asthmatic patients. These interventions include workshops, events, conferences, and lectures. However, most proposed intervention tools lack practicality due to high cost and time requirement, and suffer from low pharmacist engagement, and particularly over a long period of time. Further, face-to-face educational events could increase the spread of COVID-19. So the objectives of our study, first, to develop an educational intervention approach that could be used to improve pharmacists' ability to identify MRBs and provide recommendations. Also, to assess the acceptance rate for the pharmacist intervention on medication-related problems, and to assess also the clinical value of pharmacist intervention. Finally, also to investigate the frequency and typology of medication-related problems in community pharmacies in the UAE. Overall, 104 community pharmacies were recruited and randomized to either the intervention or control using a 1-to-1 allocation ratio. Pharmacists working in pharmacies assigned to the intervention group received a series of MRBs related clinical case scenarios delivered through WhatsApp over the course of 1 month. And pharmacists in the control group received no intervention. Then both groups reported MRBs and their recommendation for a period of 5 months using a standardized data reporting form. The inclusion criteria for pharmacies were working on regular basis, yani open at least 6 days a week, operating at least 2 shifts, and have significant staff to cover the absence of pharmacists in case of emergency need. Serving also more than 20 customers per day on average, and having a stable internet connection. The exclusion criteria for the pharmacies were if they are open for less than 6 months, employed only 1 pharmacy employee, or were located more than 10 miles away from the nearest clinic or medical center. So the intervention instruments was 21 clinical cases, comprising 44 prescription and 72 medication orders. 7 of the cases contained 1 MRB, 10 cases contained 2 MRBs, and 4 cases contained 3 MRBs. So each case includes current prescribed medication, past medical history, the sex, the body mass index, age, diagnosis, comorbidity, and laboratory values if needed. The resolution for each case was also added. So the key findings as the MRB incidence across the intervention and control groups was 0.46% versus 0.09% respectively. So our educational intervention may be useful for improving the ability of pharmacists to identify MRBs. Also, MRBs related to efficacy, like the need for additional or more effective therapy and the need for higher dose, and also safety, wrong drug owing to contraindications, high dose, and risk of adverse drug reactions, also, and poor knowledge where those most common MRBs was detected by pharmacists in the intervention group. The proportion of efficacy-related problems, safety-related problems, poor knowledge problems between in the intervention and in the control group, where they found like 27.5 versus 5.8. So it is highly significant, and also 28.4 to 25.8 also in related to safety related problems, and for poor knowledge problems 21.8 versus 3.9 respectively. So the mean time needed to resolve MRBs for patients with major polypharmacy by pharmacists in the intervention group was 6.82 plus or minus 3.8 minutes, was significantly lower than that reported by pharmacists in control group, which is 10.78, almost 11, plus 6.3 minutes. Also, pharmacists in the intervention group recommended a resolution of 1,284 cases of MRBs, around 82.9, around 83 were accepted, 28.4 suggestions were for cessation of the drug therapy, and 22.3 suggestion for patient education. Also, exactly 18% of the pharmacist recommendations were deemed significant, and most of the recommendations were carried out to resolve MRBs in patients with moderate and major polypharmacy. Pharmacist intervention with significant clinical value were significant, determined for patients for physician acceptance of pharmacist recommendation. We found that pharmacists face a new challenge that require constant learning, and educational tools are needed that apply reflective clinical skills and practice and empower pharmacists to take major role in patients' care. We found also the current study may contribute to alleviating two problems that have hindered improvement in clinical practice. First, elimination of communication barriers between pharmacists and educators. And second, the method applied to this study considered the baseline cultural differences among participants by customizing educational material for each participant. We find in the Khan Janani study also they used an interactive workshop method to improve the clinical knowledge of pharmacists with regard to medication-related problems. They found that clinical case-based workshops could improve the ability of pharmacists to detect MRBs. However, their study had two major limitations. The first one, the intervention period was very short, and we believe that it is unlikely that such a short workshop duration could significantly affect the knowledge and the skill of pharmacists on this topic. Secondly, also we found that the outcomes were assessed using a survey, which may not reflect the actual impact of educational intervention. Additionally, this approach for educational intervention suffered from poor pharmacist engagement because the intervention occupied a great deal of their time and was costly. A previous study have shown also that efficacy-related problems are common in many countries. Nonetheless, most of these studies did not test the impact of educational intervention on the ability of pharmacists to detect MRBs and intervene appropriately. Instead, they measured the impact of the intervention, such as clinical pharmacy implementation, medication use review, and patient education on MRB rate and types. In summary, the finding of the current interventional study could be helpful for identifying an applicable and time-effective educational approach to improve the ability of pharmacists to identify and resolve the medication-related problems. Especially our findings could improve the clinical outcome of pharmacist intervention upon detection of MRBs. Our study demonstrates several factors that affect physician acceptance of pharmacist recommendation. Further research also on collaborative practice between community pharmacists and physicians in a primary care is necessary to optimize the communication method and correct any misconception of the role of pharmacists and remove any barrier of collaborative practice. Our study limitation is that the method used for outcome assessment was self-reporting. Consequently, this method may have induced intentional and unintentional reporting bias. Nevertheless, the risk for reporting bias was minimized in our study because the use of WhatsApp could blind both investigator and participants. The study focused also on process-based medication-related problems. pharmacist recommendation and the visibility of the new intervention methods, but did not address outcome-based parameters, which are vital to determine the efficacy of our approach. No assessment for the effects of missing data related to medication-related problems, and patients' clinical information on documented pharmacist recommendation was conducted. And this study is published in research, in journal Research in Social and Administrative Pharmacy, cited with me and my colleagues as a novel educational approach for improving medication-related problems in community pharmacy. And this is the references. Thank you very much for your thank you.
Thank you so much, Dr. Nadia. It was very informative presentation and research as well. So let's go to the panel discussion, and let me invite Dr. Dominique Jordan. He's a president of FIP, and Dr. Catherine Dugan, she's a FIP CEO, and Dr. Zahir, he's a president of JoPPP, and Dr. Nadia Mazroui, she's a president of EMRO Pharm, and Dr. Rola, she's a professor doctor in University of Jeddah. Okay, so as we wrote, and the FIP event just wrote that if you have any question, please feel free to write down your question, or even in the Q&A, and we're gonna answer that question. So let me thank you so much for coming, and thank you so much for attending this panel discussion. It's very important to discuss a lot of questions. We got it already, and during your presentation as well. And let me convey something that's very interesting for me, at least. We have attendees, our colleagues from, as I said, Jamaica, Philippines, Qatar, Iran, Indonesia, India, Bangladesh, Sri Lanka, Egypt, UK, Malaysia, Bulgaria, Cambodia, I like this, and Emirates, China, from Macau, and Argentina, Pakistan. We have a lot of countries. We have a lot of friends and colleagues from all of these countries. So it will be very informative session. I believe in that. So let's go to the first question. I get this question regarding to the vaccine from Dr. Ganan Chandran. I hope I pronunciation your name is good. I guess this question for Dr. Dominique. He asking about the third booster dose of COVID-19 vaccination globally, and FIP rule and responsibility from FIP. Please go ahead, Dr.
Thank you very much for the question. That the trend is that people older than 65 years old has to make a third vaccination in many countries. We are discussing that, for example, in Switzerland, in US, in France, in different parts of the world. What is sure is for people with chronic diseases, a third vaccination will be good. This is what the experts are discussing for now. The role of FIP in the vaccine, of course, one of the most important roles for me is access to medicines. And when we see what happens in many countries, that not even 2% of the population is vaccinated, not because they are not willing to do that, but because they don't get the vaccine. This is also for high-income countries very dangerous, because it could have a boomerang effect. And if we want to be successful fighting this pandemic, I think we all have to fight that everybody gets the needed vaccine. And this is, for me, one of the most important role in vaccination. Of course, all the advocacy, helping the member organization, being an actor in vaccinating people in their own country, legislation, adaptation, and supporting the country willing to do that is a mission of FIP. But one key issue in the fight against this pandemic will be to get access to everybody, or to give access to everybody to the vaccines.
Thank you so much, Dr. Jordan, for answering. And let's go to the, this is a part of this question also, but I guess this is for Dr. Nadia. Do you have the same, doctor, he said third booster dose of vaccination of COVID-19 is administered in Emirates? Did you starting already, Dr. Nadia, there in Emirates?
Yes. In Emirates, they provide the vaccination. Nearly now they reach to 90% of the people to be vaccinated in the country. Almost, they took the first dose, sometimes the second dose. The third dose, there is some people is taking, and we shift to giving to the children, or before in the school, to the students. They start giving them also the vaccination. I agree with Dr. Jordan that vaccination, it should be available for everyone. And that's what we are doing. It is free for everyone in UAE. Either if he is a local, he's original from UAE, or he's expatriates, or he's coming for a visit. We offer, our government, thanks God, they offer the vaccination for everyone here. And they're trying also to help some countries to give them also to donate some vaccination, as we were sharing in the research phase of Wuhan, of Sinopharm vaccines in China. We were with them, so we are trying to help as much as we can. And the question is, we are expecting now a third phase or the fourth phase. And is this vaccine will cover also these things? This is the challenge for, not for Emirates only, it is worldwide. Is it the same strains, or it is a new strain is coming? And is the vaccine is covering all these or not? But this is the win, what we are, all of us, of course, this is a worldwide challenges. I think,
yeah, that's okay, go ahead, sorry.
No, okay. I think it is through us, we are trying to help each one, helping the other countries also, because this is a global challenge, not only a person. We are trying also, anybody who's coming to UAE, we give them the vaccine, everybody. It is in a way that we are trying our best. The Gulf region, they're trying also to vaccinate. There is a variation, some people, but in UAE, we have most of the vaccines, which is, we have Pfizer, we have Sinopharm, we have, everything is available if anybody want to come, and it is, mostly it is free of charge.
All right, thank you, Dr. Nadia. Thank you so much for the informative answer. Okay, this question going to Dr. Catherine. His name is Dr. Kashal Supidi, I guess. How was the major polypharmacy defined, and what about the development goals of FIP and how can implement it? Yep, please go ahead.
Thank you, Dr. Wael. So I think in some journal articles, polypharmacy has been defined as more than 5 medicines in many countries. But we might consider a very pragmatic approach to polypharmacy as too many medicines for that patient in front of us, perhaps. And that way we take a very patient-centered approach. And what we've done in the team at FIP is to cluster together the goals that really relate to NCDs, prevention and safety. And if you think about polypharmacy, that really is at the center of all 3 areas of practice. So I would say initially, that's a safety issue, that's a patient-centered care issue, that's very possibly a sustainability issue as well. But also, can we offer that patient any advice to prevent the need for more medicines to be added to their regime? And I think that way, if we start to think about the goals as being overarching, a big umbrella to help us just describe and define, and then think about what our pharmacists have been doing, Dr. Wael, in the pandemic, it's about managing the patient who's in front of us every day and thinking about how we can help them prevent getting worse, manage their conditions to the best they possibly can, take the least amount of medicines for the biggest impact that they possibly can, and to make sure that we ensure that they are safe with their medicines regime. So all the goals that would map onto those areas of practice are really central to the polypharmacy agenda. It would be very interesting for us to run an event on polypharmacy to find out in different regions, maybe different age groups have, differences in how we might define this. Some of our frontline staff would definitely have differences in how we define it, but also how we might undertake roles for pharmacists like de-prescribing, and how we could possibly support patients with making sure the medicines they are prescribed are the most appropriate for their conditions. I think that's my most pragmatic response, Dr. Wael. I hope that's helpful.
Absolutely. Thank you so much, Dr. Catherine. Okay, so let's go to another question. This question is going to Dr. Zahir from Dr. Nadim. How to improve pharmacist knowledge and the skills in community pharmacy. Here you go. Dr. Nadim is talking about, this is a very informative question. This is a community pharmacy. They need a lot of, working. So how can we, improve the skills, especially in the community pharmacy? Please go ahead, Dr. Zahir.
No, thank you very much. I think it's a very interesting question, but I would perhaps go back to the country in which pharmacist is working, because during the pandemic, what we have seen is that we have seen a lot of disinformation and misinformation. And this is being seen one of the biggest challenge across the globe, whether it's a high-income country, middle-income country, or a low-income country. Of course, the skills would be different, in terms of if we are dealing with the patients. But I think one of the generic thing which I sort of observed in the literature as well is that how pharmacists can counter this disinformation and misinformation, because as a healthcare professional, how they can actually tell consumers about vaccination, for example, that if they would go for vaccination, it's safe to be vaccinated. And it's across the board. Also, it's important for the healthcare professionals too. But I think for pharmacists, they can really play a very important role in this context. And coming back to the second part of the question, there is a lot of improvement for especially the countries which are in EMRO region, which are mostly low and middle income countries. But then we also see a lot of high income countries which are developing their health systems. So for example, United Arab Emirates or Kuwait and Saudi Arabia, these are rich countries, but they're developing their health systems. So in terms of research, we have seen that there are a lot of opportunity for people to improve their skills, whether it's for the minor ailments or whether it's for blood pressure testing or whether it's for vaccination. So I see it's twofold. One of the skills in terms of hands-on practical skills, and the second one is more sort of conceptual, whether they can contribute to counter the disinformation about whether it's medicines or vaccine, or whether it's the general medicine information, providing the public about authentic, independent medicine information, that whether this medicine is good, or whether about drug interaction, whether about adverse drug reactions or anything, or which could be conveyed to the consumer in public and lay language. Australia has been very good in this context in starting their consumer medicines information program, which Australia started 20 years ago. And I think there are other countries which can learn lessons. The other countries, they can learn lesson in this context. Thank you.
Thank you so much, Dr. Zahir. It was a very informative answer. So let's go to the, like a pharmacist manufacturer, how we can create pharmacists. Create pharmacists mean you have to have education. Education, it's like matrix of all science we collect all years we are studying pharmacy. So right now, Dr. Arola, she's a professor doctor. She's talking about what about the accreditation? I mean, like international accreditation in the pharmacies, education. And, I guess this is many countries right now, they found something, it's a very, bad era, like someone make like a course, what this pharmaceutical course in anything, just to collect information and hey, this is course, just to pay money, and this is my course, that's it. So how can we control this randomization in the education and education, let's say, accreditation? So, Dr. Rola, can you speak about this thing, please?
Thank you, Dr. Wael, for your question. Very important one. I believe in education a lot. And for, I will catch up where Dr. Zahir has finished. In order to make any intervention, you should be armed, or the pharmacist should be armed with the proper education. And that's why if I have to propose, I would have looked at the goals of the FIP and put the education as a pillar, actually, not only workforce and education. I would put it like a separate one. Because if you start from the base, I'm sure later on you can build on this information. And even after education, again, the education is very important through the continuous professional development. And this is very important. Now, for the era that we are in, the COVID-19, actually, we started, I'm just going to give you some example of our experience in Jordan. We have included, it was already there, the immunization course, but now it has more emphasis on the role of pharmacists in applying or in giving these, especially in COVID-19. So it's really important. As for the accreditation, like Dr. Wael was saying, it's very important not only to make just a course and that's it. You have to have certain standards, certain outcomes that you are looking for at the end of the day. You're going to see if the achievements of your students, which are our outcomes in this case, they are achieving what you are looking for. And we believe also, even if you want to make accreditation, you should look for the agency, the proper agency for this. The accreditation is something really connecting all the words together. Just a little bit earlier, you were talking about one FIP. It's not only one FIP. One FIP is very important. We know that FIP is the umbrella for all pharmacists. Again, all schools should also work as unity, and the pharmacist should take his normal role as part of the healthcare providers. He should be able to provide, but in order to do that, you have to prepare the pharmacist in the proper way. So you have to look at the programs, the curriculum is very important. It has to be built up on certain standards in order to achieve the outcomes that you are looking for. Again, the accreditation is an ongoing process. It shouldn't be, it's dynamic, it's all the time changing, and it should take in consideration what's going on around us. We want, at the end of the day, the pharmacist to practice with his science and with his education properly in the community and take his position that we are looking for. So education, accreditation, and what FIP is doing also is very important. And we look forward for pharmacists with armed with all these pillars. Thank you.
You're welcome. Thank you so much, Dr. Ola. Okay, this question is going to, this is like a final, let's say, term to Dr. Dominique. This question coming from Dr. Sherry. One of the goals in the future would be dispense vaccine right in our own pharmacy, as well as becoming an immunity or immunizing pharmacist. Should we need to have a special prescription for that from physicians, or are we allowed to make decisions for that in our walk-in patients? What do you think, Dr. Dominique?
So my response is quite clear. No, we should not need a prescription. We have to assume our role as a pharmacist who is allowed to vaccinate. And this is part of the education. If we have the right education, we can take this responsibility. And one of the big problem of the pharmacists in the past was, I have a prescription, I don't risk anything because it was written on the prescription. No, this time is finished. We have to move forward, take our responsibilities. We want to be part of the health system, and we have to assume if we take a risk, it's our own responsibility. It's a reason why I say the legislation should be that the pharmacist with their own responsibility can decide if a patient is the good one for vaccination, for tetanus, for COVID-19, for flu, and so on. But this is, for me, mandatory, or to do that, this is mandatory to have the right education. And without the quality education, the pharmacist will not be able to meet this challenge. But to be clear, the responsibility under the responsibility of the pharmacist without prescription of the doctor.
Awesome. Okay. So Dominique, here, this is another question from Dr. Edim regarding to the third poster. You know, he said, thank you for your presentation. And the third poster dose, will there be any other dose for an individual to take? You know, he's very worrying as us. So if so, what is the expected number of doses one should take to be completely protected from the virus? You know, it's like a series of vaccine poster, first, second, and then now they are talking about third one. What about if we fourth or fifth? What do you think?
Yeah, I think we have to trust our experts. One thing we don't have to forget: this is a new disease. We are learning. It's a learning process. With the months, with the years, we will have more information, more data, more research about effectivity of the vaccines, or if we have enough immunity with two, for how long, and we need a third one. I don't think it's very important to think about did we get enough dose, because we will get enough doses. The question is price, access for everybody, and maybe possibility to convince the population that vaccination is the key for success against this pandemic. So that wait until our experts are clear. I think we have to wait a few months until the studies are finished. And then I don't think it will be a problem to have enough doses. The problem will be to share the doses with everybody.
Yes, awesome. You know, this is a kind of individual asking from while to the president of CEO on live, you know. You know, yeah. We need to make like an official FIP statement for the people. Yeah, please, this is a countries never get any, you know, first vaccine. So, and the other people, they are talking about the third vaccine, you know. Yeah. They have to know this infected people can infect them again, you know what I mean? So we have to say, please don't start like massively make a third before the people, they get the first vaccine, you know what I mean? By ethical way. What do you think, Mr. President?
This is a big issue and really a question of ethic. We discussed this issue also internally with our people in Switzerland and so on. And of course, the role of each government is to look at their own population. I don't think that everybody who is not vaccinated, also in low-income countries or in countries that they don't have enough vaccine, that it's only because they don't get the vaccine. Because I know some countries shared, and we had the example of Nadia before, shared some vaccines with other countries. And I know that some countries had to destroy some vaccine because they were no more good for using it for the people, because the people didn't want to use it. And this kind of discussion should also be part of the whole discussion. But of course, now as a human being, we should have a plan, and this can only be a global plan, how we can get rid of this pandemic. And I'm convinced that can only happen if we look at the equity of the sharing of this vaccine with all the countries. I don't want to discuss of 1, 2, or 3 vaccine, because this is not the issue. The issue is the people in all the country who are willing to get the vaccine should have access to this vaccine.
Thank you so much, Dr. Dominique, and thank you for accepting our invitation for this panel and this conference. Thank you so much, Dr. Catherine. Thank you, Dr. Zahir. Thank you, Dr. Nadia. Thank you, Dr. Rolla. And we are behind the schedule already, so we are so sorry for attendees and for you also. So let's go to the another part in our day today. And Dr. Rolla and Dr. Nidal, they will be our moderator right now to start the part 2. Thank you so much.
Thank you. Thank you, everyone. Thank you.
Thank you. Dr. Rolla, Dr. Nidal, can you hear me?
Yes, yes, we are. But I think there is somebody would like to have a break.
No, it's okay. We have to start. We are behind the schedule already, so there is no break. Please.
So you change the schedule.
Yeah.
Okay.
So our moderator now, Dr. Nidal Mary,
yeah.
She's a professor, Dr. College of Pharmacy, Mustansriya University, Iraq, and Professor Dr. Rolla Darwish, she is a Professor Doctor of College of Pharmacy, Jordan University from Jordan. So please go ahead, and this is your floor.
Yes, thank you very much, Dr. Wael. It's very nice to participate in this event, even as a moderator, and all the lectures are actually very important. Our next second session, we will start with our first speaker, the role of accreditation in education transformation. Professor Karim El-Zubaydi is the Dean of the College of Pharmacy at the University of Sharjah, UAE. You are welcome, Dr. Karim, and we will be happy if you start your speech.
Thank you very much. Let's see if I'm allowed to share my slides. Okay, you should now see my slides, right?
Yes, it's clear.
Okay. So thank you very much for the organizers for the FIP organization, Dr. Wael Ali, Dr. Nadia Al-Mazroui, and everybody else for having me as part of this event. I will talk really briefly about the role of accreditation in education transformation and how it really, the accreditation agency and the educator, the college, could work hand in hand to improve the education in pharmacy and elsewhere. So thinking back a bit into who are the stakeholders in the pharmacy profession and how educators and school fits into that picture. Well, we have the regulators, we have the colleges, the educators, and the practitioners. And those three groups or those three stakeholders are feeding into each other and working hand in hand to, at the end of the day, our goal all in the medical field is to provide best care to the patients and to the community and best health services. Now, from our perspective as pharmacists, that will be optimal pharmaceutical care to the patient. And here comes at the front line, the practitioners, who are the pharmacists working in the field, in the community pharmacy, in the hospital, or those in the work as clinical pharmacists, and represented as individual pharmacists, as care providers, and as part of the pharmacy organizations, bigger organizations. Now, those practitioners are the ones that are on the ground, feeling the needs and feeding back into the educators and the regulators about what's needed, what are the competencies, what are the required skills that are emerging every day based on the country needs, based on the world need, and based on the need of the public. And the regulators comes into the scene as governmental agencies, semi-governmental, and accreditation agencies as well. And public forces all come together hand in hand to shape the regulation that will shape the competencies based on the feedback of the practitioners. Now, us as educators are the providers of the knowledge, of the science, of the ethics, values, and professional skills needed from the pharmacists to be practitioners in all aspects related to the pharmacy profession. So that's how probably the whole picture or the whole theater of pharmacy is going hand in hand, all stakeholders going hand in hand to shape the pharmacy world of the pharmacy profession. Now, this takes us to the need-based education model of pharmacy, which is really very owned by the FIP, in fact. And here, there are services that are needed, and I'm starting from the right. There are services that are needed to be provided by the pharmacy workforce. And those services have to meet the needs of the country, the region, and internationally. And depending on that, we provide the services and we shape the competencies. And we involve the public, and we are care that the public get the best services, care, medical care, and we provide their needs and their demands as well. So that's one of the major feedbacks that will shape the competencies. And we take these competencies as educators and try to deliver them into those young going generations in the market. Now, during this process comes the quality assurance and the accreditation, ensuring standard delivery, ensuring we meet and we provide what we should provide in a standard way, in a consistent way, in a replicable way as well. So accreditation in education is about quality assurance, but as well quality advancement. Those educators and those colleges who have been through several cycles of accreditation, they will know exactly what I'm talking about. Accreditation should take you by hand and standardize the system of your education or of your college and improve that and build on your uniqueness and your own strength, cover the weaknesses, and go on hand in hand with you to advance the quality. That's the idea of the accreditation and how it should improve the education. It's not a matter of filling files, showing files, and visits of the committees. No, it's really about the improvement of the quality. It's a culture that you build in your staff and in your faculty members. And this culture will go for the life of this college and for generations to come of educators and professors. Thus, we're talking here about advancement of equality through the accreditation and through the criteria that the accreditation will push for and ensure that they meet a certain core equality or a certain standard. And that's where accreditation serves to standardize the educational process, make it consistent. So I will provide a consistent education based on certain keystones or certain milestones that I should achieve or competencies in other words. Yet, we are not going to be copies. The colleges will not be copies of each other. No, each college will have its own individuality, its own uniqueness. So, though the accreditation will ensure standardization, it will not deprive the program from its uniqueness, and thus it's the specific delivery of the curriculum or the specific delivery of the competencies needed is really a program or provider driven. And that's the idea. We don't want to create copies of colleges in different universities. No, we want to build on the strengths in each college, cover the weaknesses, try to remedy those, ensuring all colleges are meeting what's needed to be met, yet keeping their own uniqueness and keeping the innovation thus going. Because if we're going to have all the same, then we are killing the innovation. So it's really a matter of give and take here in the accreditation. So when a college goes into that experience, probably the start will be lots of files, lots of paperwork, and lots of requirements, sometimes really annoying to the individual faculty of the individual members and even to the management of that school. But with time, and the more you believe in it, the more you will start feeling the difference and how it's really improving the quality of the education, the quality of the delivery. And the other important thing that as a college management and as a faculty member in a college or as a college council, you will know where you are in the educational process and where you're heading. What is your milestone? What are the things that I want to achieve in the educational process? And what are the competencies that I want to meet? What are the things that I'm a bit weaker on and I'd like to improve? And where are my strengths that I want to keep or even go stronger in those? So it's really enlightening. It's an enlightening process. That's how accreditation really, I would say, dissects the educational process, shows you the anatomy of it under the microscope. And that's where you start improving and you start developing the educational process, the delivery, the competencies, the skills given to your young generations of pharmacists. So pharmacy education today, we have to provide a certain structure of certain competencies, and we have to go through the process of delivery, and then we should get the outcomes if we are delivering the process the right way. But again, these outcomes or those graduates, we should see their impact, their practice, their skills. And those skills should fit into the context of the country, context of the culture, context of the continent that I'm delivering those pharmacists for. And at the base, we always have the science, which is the base of everything. Feeding into practice, so we have practitioners. Pharmacy is a profession all about the practice. And what ties everything together is the ethics, the attitudes, the values that we cultivate and we put in our young generations, so that we provide pharmacists that are competent, able to practice, have a strong core of science, and have high ethics values as well. Thank you very much, and I'm ready for your questions.
Thank you very much, Dr. Karen, for your nice lecture. And the accreditation is a very important point, actually. The questions will be at the end of the session, I think.
Okay.
Thank you. The second speaker will be Dr. Adel Sadr from College of Pharmacy at Al-Ain University, UAE. You are welcome, Dr. Adel. And we are happy to hear you.
Bismillah ar-Rahman ar-Rahim. Thank you for inviting me to this lecture, which is very important in the educational program of pharmacy. And also we will discuss a new topic, which is about interprofessional education, challenge and solutions overview. Thank you for inviting me to discuss this topic. First, we will discuss the objective of our lecture, which are interprofessional education, which is the key message for that, the need for interprofessional collaboration, key concept and environmental scan of interprofessional education practice, the challenges and barrier to effective interprofessional education, possible solution in the design and implementation of IBE, creating new ideas and fruitful effort for IBE or interprofessional education. First, we will go to define interprofessional education, in which patients have, we know that patients have complex health needs and typically require more than one discipline to address and to be with expertise regarding the health of patient. In 2001, we start with the recommendation of the Institute of Medicine Committee on Equality Healthcare in the United States, which suggested that healthcare professionals working in interprofessional teams in their field and can best communicate and address their complex and challenge need when they are with interprofessional education and collaboration. This interprofessional approach may allow sharing of expertise and perspective to form a common goal of restoring or maintaining an individual health and improving outcome. Interprofessional education is an approach to develop healthcare students for future interprofessional teams. We understand that a student trained using an interprofessional education are more likely to become collaborative interprofessional team members who show respect and positive attitude toward each other and work toward improving patient outcome. The key message of our lecture regarding interprofessional education by WHO and its partners recognize interprofessional collaboration in education and practice as innovative strategy that will play an important role in mitigating the global health workforce problem and the crisis. IBE occurs when students from different or from two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. IBE is a necessary step in preparing the collaborative practice, which ready to better prepare to respond to local health need. Collaborative practice ready health worker is someone who has learned how to work in team, interprofessional team, incompetent to do that. Collaborative practice happen when multiple health workers from different professional backgrounds work together with patient families, career and communities to deliver the highest quality of care. Collaborative practice allow health workers to engage an individual whose skill can help to achieve local health goal that we find after almost 50 years of inquiry. WHO and partners acknowledge that there is sufficient evidence to indicate that effective interprofessional education enables effective collaborative practice. Integrated health and education policies can promote effective interprofessional education and collaborative practice. The evidence, which was based study, indicated that a range of mechanisms clarify the effective IBE and collaborative practice. These mechanisms include supportive mechanism in which supportive management practice, identifying and supporting champions, settlement to change the culture and health worker attitude, a willingness to update, renew, and revise existing curriculum, and appropriate legislation that eliminate barriers and the challenge to collaborative practice. Interprofessional education sounds great theoretically, but can it be done successfully? We don't have a lot of successful model for merging complex system without one system dominating or taking over the other. Interprofessional collaboration need for our healthcare system because health policymakers have shifted their focus from a traditional delivery method to innovative strategy that will strengthen the health workforce for future generation. There is a great deal of interest in moving IB collaboration forward, but the desire to engage in this type long-term planning is often sidelined by some obstacles or some urgent crises that may occur, which such as epidemic of some disease like corona or COVID-19 or AIDS or tuberculosis, or spiraling healthcare cost, natural disaster, aging of population which increase, and other global health issue which put more money or more expenditure to the health system. Fortunately, many policymakers are recognizing that a strong, flexible, and collaborative health workforce is one of the best ways to confront this highly complex health challenge. In the recent year, we're supposed to know that a number of local, national, and regional associations and academic centers of excellence have been launched, demonstrating the growing momentum or incentive for interprofessional education. When interprofessional education, there is collaborative practice which can positively contribute to some of the world's most urgent health challenge. So, building a regional network to support interprofessional collaboration not only ensured there was no competition for funding between projects, it also made it possible for all interprofessional projects to share best practice, challenges and opportunities. The Center for Advancement of Interprofessional Education, CAPE, has competency for interprofessional teaching, which include the following: commitment to the education, understanding of role or responsibility in the different profession, positive role modeling and understanding group dynamic, valuing diversity and ability to use professional differences creatively within groups, deep understanding of and skill in using active learning methods, and expect facilitation. There is 10 tips for effective interprofessional group facilitation, which is supposed to be for the education, interprofessional education is supposed to be prepared, know your learner, and invest in the beginning, create a safe and open environment, understand and respond to group dynamic, encourage diplomacy and allow for various perspectives, be positive role model for interprofessional collaboration, monitor the situation and maintain neutrality and sensitivity to focus the conversion on IB practice and collaboration, and have a closure for this type of education. Key concepts that sharing and supposed to understand interprofessional education. We're supposed to know what we mean by health worker and interprofessional education that we clarified, collaborative practice and health and education system, health worker, that all medical staff that sharing the care system, collaborative practice in healthcare or care, when multiple health workers from different professional background provide comprehensive services by working with the patient, their families and careers, and communities to deliver the highest quality of education. Health and education system consists of all organization, people and action whose primary intent to promote, restore, or maintain health and facilitate learning respectively. They include effort to influence the determinants of health, direct health improving activity and learning opportunity at any stage of health worker career. Also, education is any formal or informal process that promote learning, which is an improvement in behavior, information, knowledge, understanding, attitude, values, or skill as defined by the National Educational, Scientific, and Cultural Organization in the United States in 1997. The basic assumption that we're supposed to know that we believe everyone participating is intelligent in interprofessional education, but everyone participating is intelligent and supposed to be well trained, cares about doing their best and want to improve. Everyone has have the power and have the decision to improve, and is valuable member of the interprofessional team to be one of those medical staff. The partner, as you see here, they are community doctors, nurses, nutrient, occupational pharmacists, physician, and so that sharing the health system. A challenge to interprofessional education that we meet include 3 different classes of a challenge or barrier, such as educational, structural, or cultural challenge. In educational challenge, we have the lack of availability of a professor. Developing the faculty member is recognized as key factor in the success of any interprofessional education project. Studies stated or reported that lack of individual skill and commitment at the college level is a barrier to interprofessional education. University professor and the clinic need to prepare themselves for interprofessional education, especially for facilitating role. Increasing collaborative activity at different faculty increase the awareness and interest of faculty member from IBE, although many institutional and individual barriers may prevent their full involvement in this as a leader. Introducing and clarifying the benefit of interprofessional education as strategy in raising awareness. From the educational barrier also, we have non-flexible curriculum in which that traditional curriculum was identified as another barrier or a challenge for education. Nowadays, in almost all university students of different health professions are educated in separate classes, not sharing, or in a clinic setting without the opportunity to interact and share information, recognize the role, and perceive the differences, commonalities and abilities, responsibilities, and shared goals. In some countries, such as Canada, the main obstacle to the interprofessional education timetable were the dry curriculum of Canadian and the defect in the perceived value of IBE. Also from the educational, that weakness in current education, in which dependence on a traditional theme-based single discipline and isolated educational approach is another important challenge for this. Education is an isolated condition, create worldwide language, culture, and attitude specific to each profession, different from the other. The appearance of a prejudice pattern and specific mental forms, territoriality and extremist tribalism, negative competition, imbalance of power, and superiority seeking. A bridge which is one study this challenge, he stated that the most important adverse effect of isolated and separate education of health professionals include the disruption and failure in the process of professionalization and socialization of the student, and consequently unfavorable professional behavior. Centralism also and hierarchy of power, poor educational groundwork, and lack of support were structural challenge for educational interprofessional education. Now, in addition to education, we have a structural challenge. In a structural challenge, there is centralism and hierarchy of power. According to some study, the existence of hierarchy, existing program, construct convention, the construct of the current health services, public perception, the current practice domain, financing and planning were the challenge and barriers for this transmission. Power distribution is one of the most challenging discussions in this field. Also from a structural, which is lack of organization support, like executive level barrier mainly include an understanding of whether IBE worth direct investment and the change of institution mission. It is important for managers to understand the need for a change, and political support or governmental support for IB can help create motivation for educational institution. And in the literature, there is consensus that the success of any interprofessional project depends on attracting the commitment of institutional and political leadership. At level of academic institution, it is mentioned that the support of senior manager with the decision-making power in education and best education policy and resources also needed to support this transfer to interprofessional education, in which we gain support from key senior manager can help to release this challenge. And faculty member also need to understand the benefit of interprofessional education, and faculty member may resist due to increased workload and shortage of time. This is of the challenge for manager are responsible to motivate faculty member to make a change and development and resist them. From the structural also inadequate infrastructure, the operational management of the educational system in many professions require a change in the curriculum arrangement, designing and implementing IBE in a structural task that faces a challenge such as course scheduling, course content alignment, resistance of faculty members and manager, and culture of valuing the collaborative learning among faculty member and the student and institution policy to share courses among faculties. Cultural also that cultural challenge also affect the transition to interprofessional education, in which destructive attitude and resistance to change, the cultural challenge arising mainly due to the attitude of manager, the professor, and the student affect the IBE design and implementation of this type of education. Barrett et al. In his study urged the attitudinal differences in his profession, faculty member and students, such as lack of resources and commitment, could negatively affect the IBE implementation. So inappropriate cultural environment in universities and hospitals, especially in educational hospital, create an inappropriate learning environment for IBE. Therefore, in most educational programs, an inappropriate, professional, and individualized culture is recognized. Such inappropriate culture for IB originated by authorities from curriculum developer and designer to faculty member in this process of education. Cultural also include non-commitment of faculty member for the transition to the interprofessional education. A professor needs to engage in acquiring a skill, improving quality, patient safety, and interdisciplinary interaction within the healthcare system to teach content and serve as role model and monitor for students, in addition to the role of belief, in addition to the role of belief and value in the essence of interprofessional education, attitudes continue to be notes as an ideological element. Significant emphasis of almost all participants highlight the importance and necessity of cultural change. The role of attitude and ideological element is very clear. The process of a changing attitude and moving toward interprofessional education require a change in the organization culture and commitment of faculty member, which is a slow and a gradual process that we find to occur during our system. The challenge, we now discuss the challenge and how is the solution for this challenge. Solutions to this challenge include solution to weakness of the present curriculum, solution to structural environment, solution to cultural environment. We will start by the first with solution to the weakness of the present curriculum. The present curriculum is unsuitable for the integration of IBE. If the curriculum is taken into consideration, that we find it every time in our curriculum, then the commonalities should be taken into consideration and should be supplemented or appended to the current curriculum. Different courses should be injected. The different courses that we have in our curriculum should be injected into the curriculum for various education environment. The professor agreed that the curriculum should be interprofessionally written and investigated and evaluated in order to identify and consider the opportunities available for this change in the existing curriculum. The point that can be interprofessionally implemented should be determined and interprofessionally educated in those particular points should be considered. In the existing curriculum, the interprofessional opportunity can be identified and reviewed, but they cannot be interprofessional in essence because they are written as a single discipline, not as a sharing disciplines. Solution to structural challenge. The solution to structural challenge or barrier in which appropriate structures were one of the most important factors affecting the IBE design and implementation. Some obstacles such as centralism, power, hierarchy, and inadequate educational environment to implementing this program. Our universities are struggling with problems such as centralism, level of power, and unique structure where IBE can be raised as a solution. The hierarchy of power must be eliminated, and the students should see each other in the same level. It is very difficult to implement that in such education in the hierarchy field of some countries that we observe that. Policymaker and educational manager have not yet understood the need to use IBE as a useful approach in solving health professional problem after completing their education, despite their concern about health professional education and work and searching for a new educational method. IBE would be difficult and almost not implementable without the support of various organizations involved in education. Almost all of the challenge of medical science and educating students separate from each other and have little interaction in the shared field of education because of their distance, as well inappropriate physical space. Appropriate educational environment should be developed in our planning for designing and developing IBE initiative and a project in the country education system. As long as people are physically distant, they lack sufficient opportunity to interact and get familiar, and thus will have a trouble cooperating. Regarding the need for interaction and cooperation in the IBE, this acknowledgement to physically connect student and the professor, certainly over time, a student will somewhat work together and in their work in the future. Solution to the cultural, which is the third point in our suggestion for solution, cultural environment, then appropriate cultural environment, create an inappropriate learning environment. This inappropriate exists for IBE at the all level, including curriculum, directors and the planner, faculty members, and even students. In order to overcome these obstacles, the educational official of different professionals should have more interaction with each other. This problem is seen not only at university, but also in a clinical setting and the clinical practice where there are attitudinal problems. Basically, our problem of attitudinal problems are mostly related to attitude to each other because our look is either all or nothing. Our look is either all or nothing. We usually find this attitudinal problem that we feel that when we discuss with the different healthcare system. In my opinion, the attitude dimension of education has not gone with another dimension. In many universities, there is now a tendency toward putting together the student with the same field or the same class. IBE require more attitude intervention than technical intervention. It is necessary to work on the attitude of people before the implementation of curriculum, because all competencies must take place within the cultural context of the country. Because of resistance against the shift to IBE in manager, changing the attitude is one of the requirements of moving toward successful IBE and break this resistance. Many universities and institute managers are reluctant to conduct this type of education, the interprofessional education, due to problems such as financing, executive issue, and the resistance of the professors. Successful IBE require enthusiasm, commitment, and positive attitude toward the other disciplines, individual and team work. An interprofessional professor with a positive look at the rest of the profession can contribute with this opportunity in clinical care services. Care is provided as a team, but the problem is that the member of the group often don't know about being a group or don't recognize themselves and don't consider that this group should cooperate with each other intentionally, consciously, and in a programmed manner. In many cases, students of other disciplines consider themselves higher than other disciplines and are reluctant to cooperate and interact with their destructive effect on the health system and revealed after graduation. Students of different disciplines lack a good attitude towards each other, which provoke hatred. When people are employed, they show a series of strange behavior, bad attitude, and suspicion are found among different people. If they were normally educated since the beginning, while knowing all the limitations of each other, they will respect and realistically accept each other when they are going to the field of work. At last, our conclusion that considering the ever-increasing complexity of needs and healthcare services, the importance of teamwork and participation in the provision of more healthcare services become evident. Medical science education is inevitably required to use IBE to gain teamwork skill and effective care system. Interprofessional education as a new educational approach focuses on interprofessional interaction in the education and learning process and the promotion of the socialization process of medical science students lead to acquisition of identity and the professional role, competency and capacity, and capability to develop effective interaction and extensive collaboration between professionals and the profession of comprehensive integrated team-based patient care. Educational policymakers should understand the importance of IBE and address the barriers and challenges they face. IBE challenge take place at policymaking, management, faculty member, and the student level. We're supposed to know that evidence-based policies, the establishment of IBE centers as the Ministry of Health and universities budget allocation, the design of IBE courses for manager, professor, and students, and the development of IBE curriculum are necessary for IBE development. One of the important ways to start interprofessional education is to design and implement small courses of interprofessional education in university that can be researched in the future. This is what I have about the interprofessional education, its challenge overview, and how to find the solution for this barrier over challenge. Thank you for your listening and attendance. And if you have any question, thank you for everyone.
Thank you, Dr. Adel. Now, since the start of new coronavirus, COVID-19 outbreak in December 2019, pharmacists worldwide are playing a key role adopting innovative strategies to minimize the adverse impact of the pandemic. Professor Dirar Abdelkader, a professor in College of Pharmacy, Petra University in Jordan, will talk to us about assessment of a new strategy to prevent prescribing errors involving COVID-19 patients in community pharmacies, a randomized controlled trial. Professor Dirar, the floor is yours.
Okay, good afternoon, ladies and gentlemen, and thanks for the invite. My presentation today is about prescribing errors. It's actually a complement of a series of research that we have conducted in the last years, specifically prescribing errors. But today my talk is about this prescribing errors linked to the COVID-19 pandemic. So the title of my presentation is Assessment of a New Strategy to Prevent Prescribing Errors Involving COVID-19 Patients in Community Pharmacies, and it was a randomized controlled trial. As you all know, prescribing errors are the most common type of medication errors, and they occur frequently in primary care. However, unfortunately, most of the studies investigated medication errors and prescribing errors in secondary care. So that's why in our study we aim to conduct this research in primary care, particularly in community pharmacies, and link this to the COVID-19 pandemic. And you know, in an attempt to mitigate undesired consequences, pharmacotherapy has been proposed as a key indication in the treatment of COVID-19 patients, and that's why we have seen many, you know, hundreds, thousands of prescriptions to treat COVID-19 patients, and unfortunately we have seen a lot of prescribing errors. So this was actually, you know, what urged us to conduct such research, and who is more qualified than clinical pharmacists to intervene on and correct prescribing errors. So the aim of our study, in addition to, you know, documenting the incidence, nature, and the seriousness of prescribing errors involving COVID-19 patients in community pharmacies, also we aim to test, you know, a sort of a new tool to educate, to train our clinical pharmacists in this pandemic. So that's why we used one of the social media platform, WhatsApp, to conduct you know, a sort of induction program on the you know, most common clinical cases and prescribing errors that happened during this. So this was a 4-month randomized controlled trial from January to April 2021, conducted in 110 community pharmacies. We used proportional sampling to have a representative sample across all government of Jordan, and over the course of 4 weeks, we sent through WhatsApp prescribing error-related clinical case scenarios to all community pharmacists willing to be enrolled in this study, and we called this group the active group. So we compared the active group who received the induction program or the induction course in comparison with the control group who did not receive any clinical case scenarios or any induction program. And after the completion of this induction program, we asked pharmacists to document all what they have seen in terms of the incidence types and also the time taken to detect these errors. In terms of the clinical severity or the seriousness, actually we submitted these errors to a multidisciplinary team of infectious disease medic, infectious disease pharmacotherapist, internal medicine doctor, in order to rate these errors for the clinical severity. We had many results. I will try to sum them up actually in these couple of slides. We aimed at 242 pharmacists working in 110 pharmacies, but at the end of the study we recruited 224 pharmacists working in 105 pharmacies. Most of the pharmacists were females, and the proportions of daily usage of WhatsApp were similar across the groups. The characteristics of pharmacies and pharmacists included in both groups were not statistically different. In summary, the incidence of prescribing errors in COVID-19 patients in the active group were 18.5% versus 3% in the control group. So as you can see, the percentage was significantly higher in the in the group of pharmacists who received the training. Obviously, they were really aware of the prescribing errors and the clinical scenarios where they need to intervene in comparison with the control group. If we go into details in terms of the prescribing errors classifications, as you can see, the wrong drug with all its sub-classifications ranked number 1. So we've got, for example, wrong drug contraindication. In total, we've got 14.04%. Wrong drug unnecessary prescribed medications 10.9%, drug-drug interaction 8.6%, and so on. Another category, which is the omission of a drug, also got 16.6% of the total, and other prescribing error categories like omission of a drug route, wrong frequency, wrong duration, or dosage form also were one of the classification of prescribing errors identified. And if we go also into details to compare between the active and the control group, you will find that the active group had detected more types of prescribing errors in comparison with the control group. In terms of clinical severity or clinical seriousness of errors, as you can see, in terms of total, significant clinical seriousness was the most common type of clinical seriousness of errors, followed by minor type, and then the moderate type, and then the serious, and finally the lethal type. As you can see also, because the active group were between brackets active in identifying the errors, you can see also there are difference in the in terms of the erroneous therapeutic categories, unsurprisingly, antibiotics ranked #1 erroneous category. 30.9% of the medications were from the antibiotic category, followed by vitamins, multivitamins, which is also unsurprising. You all know that we've seen many prescriptions of vitamin D, vitamin C, zinc, and all this vitamins and minerals. And also we've got erroneous medications like corticosteroids, mainly Dexa and prednisolone, also unfortunately given to many patients who were not really eligible to receive cortisone or corticosteroids. Also, we've seen antivirals, antihypertensives, antidiarrheals. We will talk about this clinical scenarios maybe next slide. So in summary, yes, proportion of wrong drug contraindications, unnecessary omission were significantly different between the active group in comparison with the control group. Also, the proportions of the clinical severity types, lethal, seriousness, serious or significant errors were also different significantly different between the active and control groups. And antibiotics accounted for the most common type, erroneous therapeutic category. Time taken to detect prescribing errors were shorter in the active group in comparison with the control group. This is also this was unsurprising because we expected that clinical pharmacists who were trained and received induction program were supposed to to be actively intervening on erroneous prescriptions faster than the control group. Of the 6,598 and 968 pharmaceutical interventions conducted by the clinical pharmacists working in the active and control group, which 6,013, which is 91.113%, in comparison with 61.25% were accepted by the physicians. This is one of the also aims that we've studied in this research. Something that is really promising, that doctors accepted most of the clinical pharmacist recommendations. We also studied the predictors for the physician acceptance of the pharmaceutical intervention, and we found 3 significant predictors. The first one was the addition of a drug therapy interventions. This was a significant predictor. The second predictor was errors with significant clinical seriousness, and the third predictor was interventions conducted on patients with polypharmacy. So polypharmacy prescriptions was the third significant predictor for physicians to accept the clinical pharmacist interventions. I would like just to share with you some clinical scenarios that we encountered or the clinical pharmacist intervened on. For example, a 40-year-old healthy male, suspicious case of COVID-19, who had mild common cold symptoms, no shortness of breath, but the doctor prescribed azithromycin, chlorpheniramine, and vitamin D and zinc. Obviously this is a wrong drug, unnecessary drug prescribed as a subcategory. All studies now prove that there is no clinical evidence to prescribe azithromycin or any other antibiotic like respiratory fluoroquinolone, especially levofloxacin, or vitamin D or vitamin C or zinc without a reason. So if the patient has a secondary bacterial infection, well, there's an evidence to give antibiotics. If the patient has a deficiency in vitamin D, then we can give him or her vitamin D, but we shouldn't give multivitamins, minerals, or antibiotics randomly. For example, the second case was a patient. The doctor stopped his antihypertensive, the ARB telmisartan, because at the beginning of the pandemic, there was a rumor that ACE inhibitors and ARBs may deteriorate the case of a COVID-19 patient, and this is wrong. So unfortunately, this type of error was necessary drug stopped, which is telmisartan. So it's an omission error. The patient should continue on his medication, ACE inhibitors or ARB, even if he is, a COVID-19 patient. Let me choose another clinical scenario. For example, for example, the fourth one here in this slide, the 39-year-old diabetic female with positive COVID-19, test. She had moderate symptoms, and doctor prescribed favipiravir tablet after 11 days. And we all know that this medication should be prescribed within 5 days of symptoms, not after like 10 or 11 days. It will be ineffective. And also, this patient has another prescribing error, which is omission error, because this patient wasn't prescribed low molecular weight heparin as a thromboprophylaxis, because the D-dimer was high, and the patient should receive the one of the low molecular weight heparin. This case also was really common. For example, a 50-year-old healthy male with post-COVID-19 symptom dyspnea has been on DEXA 6 mg for 1 month. So this is a wrong duration of treatment. I personally have seen many patients with DEXA. Yes, this is a good intervention, but it shouldn't be more than maximum 1 week to 2 weeks, unless he's in the hospital with a very critical case. But a patient who has been discharged and everything is all right, and there's no need to continue dexamethasone for 1 month. The patient really suffered from adrenal axis suppression, HPA axis suppression, and we have seen many patients like this. For example, one of the interventions of pharmacists, like the second case here, a 47-year-old hypertensive male, COVID-19, and he was an obese patient, prescribed enoxaparin, one of the low molecular weight heparin, 40 milligram sub-Q once. Actually, for obese patients, we know for BMI more than 40, enoxaparin 40 milligrams should be given BID, should be given twice daily. So this was an under dosage. For example, the third case here was for a pregnant woman prescribed favipiravir, and favipiravir is contraindicated in pregnancy. The last case here, a 66-year-old female COVID-19 patient had moderate diarrhea, and the doctor prescribed loperamide 4 milligram. We all know that antimotility, loperamide, phenoxylate, atropine should not be used in COVID-19. They should not stop diarrhea using antimotility medications. If you need to use, you can try anti-secretory drugs or adsorbents. Try to ameliorate the diarrhea 19 patient. In conclusion, we have seen in our study a high incidence of prescribing errors for COVID-19 patients in the primary care only. We hope to conduct the study in the secondary care in the near future. And we also found that our educational tool, the induction program conducted via WhatsApp, could help in designing a feasible and efficient intervention tool in this pandemic and its exceptional nature of physical distancing and trying not to mingle together and for any virus transmission risk prevention. Yes, it was a feasible and efficient intervention tool to encourage pharmacist involvement in identifying and correcting prescribing errors in light of pharmacists, clinical pharmacists. We always say they have a potential role in in the clinical in many clinical scenarios, and they have many roles from manufacturing to academia to research, regulation, and also in the clinical settings, either primary or secondary care. Please keep up the good work, and I thank you very much for attending this presentation, and for any questions, please don't hesitate to ask. Thank you very much.
Thank you very much, Dr. Dirar, and thank you for the three speakers. It was a very interesting session indeed. And now I get back to Dr. Wael to open the panel for discussion. Dr. Wael.
Thank you so much, Dr. Ola. Thank you so much, Dr. Nidal, for moderating this very important session. And I would love to thank Dr. Adel, Dr. Dirar, and Dr. Karim. And please, if you have any question, please don't hesitate to send it to us. So let's wrap.
Can I ask Dr. Karim, please? Can I ask Dr. Karim, please? Hello? Hello?
Yes,
Dr. Karim, please. Dr. Karim, please.
Yeah, I can hear you. Go ahead.
Yeah. Thank you. Something wrong with the net. Dr. Karim, please. This is a very important subject, talking about accreditation. We actually in Iraq, in Mustansiriya University College of Pharmacy, we started these steps of accreditation with the SPE, the American Institute, but unfortunately, due to pandemic, these procedures are actually not finished yet. So the question is, how long you think that accreditation of College of Pharmacy, in specific, can be gained from these national institutes? How long it takes, the time? Thank you.
Thank you, Dr. Nidal, for the question. Your question about the time needed for the effect of the accreditation to reflect on the school system. There was some cutting in the voice. I think that was your question. Well, I think it really appears from the first cycle, but to show an effect and to feel the improvement, probably several cycles, at least a couple of them, for the improvement and the impact to be more apparent. It's really not a matter of certain years, but rather, as I said, it's a culture that grows up with the continued cycles of accreditation among the staff and faculty of each college.
Yep. Thank you so much, Dr. Karim, for your answering. And thank you for Dr. Adel Sadiq and Dr. Dirar for their presentation. And if you have any question, please don't hesitate to contact us or send it right away. And thank you for Dr. Rola and Dr. Nidal for their moderating this session. And let's go to the conclusion. This day, it was amazing, and we have a lot of representation we had already. And hopefully tomorrow we have the same day, and we're gonna start from 3 p.m. Central, Europe time, East time. So, and we're gonna finish it almost like 5:30, the same time. So please join us tomorrow. Dr. Nadia, are you here? I would love to thank you, Dr. Nadia, and I would love to
Yes, I am here. I am here, Dr. Wael. Thank you very much, Dr. Karim, Professor Rola, and Professor also Nidal for your and Professor Dirar, and Dr. Rola. And Professor also Adil for your great really presentations. and we would like to see you in other events, inshallah. Tomorrow, we hope that you will join us. It will be about digitalization, digital pharmacy, and then will be another panel discussion. You're welcome to join us, and we will be happy to see you. It's our pleasure, really, to be here and to listen to these very informative and very nice presentations. Thank you very much for all, and thank you for the FIP, especially Carola and Mila, for the organization of and helping us really in this event. Thank you, Dr. Wael. Your efforts is really very highly appreciated. Thank you very much.
Thank you, Dr. Nadia.
Thank you.
And please let me announce regarding to the certificate, because we got many questions regarding to the certificate. Yes, we're gonna provide the certificate by your email, so please confirm your email. And regarding to the feedback, please, we're gonna share it by tomorrow, by the end of the event, just to write down your feedback by tomorrow, by the end of this conference. So thank you, Mela. Thank you, Dalia. Thank you, Farah. Thank you, Carola. Thank you, Nicole. Thank you, everyone. Thank you for everyone. Help us to get it on the right way. Thank you so much, and see you tomorrow. Bye-bye. Take care. Have a good one. Take care. Bye.